I've really tried to do is give a very broad yet specific view of the landscape and what it actually looks like when you're going out to try to get care for your loved one and obtain a diagnosis, and then all the other things, the other medical and social things that should be considered that are often not brought up in a doctor's office. So I listed some objectives, the lab and imaging tests the person might be a candidate for, and then the mitigating factors. I think we'll spend a lot of time talking about that, because even if your loved one has a neurodegenerative disease that might not be curable, there's often a lot of other things at play, such as other mental illnesses or other family structure or other medications that actually could make a really big difference, that kind of can go overlooked. We have found that a lot of people go to the doctor, they go to the neurologist, and they're hoping for a diagnosis, but they're also hoping to get a little bit more education on how they can get by day to day, and that really goes overlooked. So that's kind of where we try to fill in, and then also the education that the Alzheimer's Association has available. We often refer people to their website. So we'll talk about identifying a support system and planning ahead, which is all about why it's important to actually put a name to what you're seeing. What we have really seen is people that go undiagnosed, it just ends up being a lot harder for the family to make good decisions and manage their care, and then they ultimately don't get to be involved in the decision making that otherwise someone had taken them, because it's hard to say too, it's not really their fault, right? Because they're the ones that's suffering with a degenerative neurologic disease, so they really need an advocate to take them to get a diagnosis. We had a lady who she'd been having memory trouble for 3 or 4 years, and then she was driving and crashed her car into another car, with people inside, and then drove away. Mm-hmm. So then there was a warrant out for her arrest. She was having absolutely horrible anxiety about the whole thing. But then the advocate, the spouse, was kind of a little more kind of flippant about it and whatever else. But and then all sorts of things went on to happen to her. A diagnosis of breast cancer that was probably not really treated appropriately, and then admission to a nursing home. And it's really hard to help people even make decisions when there's no diagnosis of the life-limiting illness. So there's no name to it, and then it's really, really hard to use that as a framework to make good decisions for people. So interestingly, it's not that easy to get a diagnosis. So neurologists are trained to wait at least 6 months before they're giving you what they say is a probable diagnosis. Nothing is definitive. The research is the biomarkers and looking at amyloid kind of in the CSF and the blood, that's all growing, but it's still, the diagnosis of dementias is still clinical, because you can't see inside the pathology of someone's brain when they're alive. And also interestingly, oftentimes the diagnosis initially given can be wrong, but I'm going to argue that that's still okay, because as long as you're looking at other mitigating factors and you're looking to make sure there's not something reversible going on, it's okay if it's not exactly right the first time. If someone tells you, I think it's Alzheimer's, and then a couple years later they say, oh gosh, maybe there's a component of Lewy body from the way they're acting, and then we'll kind of shift gears. So as long as you have some kind of good follow-up, which I think people kind of should until there really is what seems to be a more definitive diagnosis, I think that's a good thing. So the path to the diagnosis, I think it's really, really different depending on the person's situation. So for example, if somebody is in their late 80s and they have a wonderful relationship with their primary care provider, and their primary care provider is well-versed in dementias and whatnot, And basically the family comes in, they say, we're noticing this, and the person, agrees with it. The primary care provider might feel very comfortable ordering a few tests and making a diagnosis without a lot of other testing, which is totally acceptable. Oftentimes, though, that's not what's happening. Oftentimes, people are going to see a neurologist that probably doesn't really know them, right? So they're seeing them for the first time, and the neurologist is saying, okay, well, you gotta get this blood work, you gotta get this MRI, and then we'll kind of do our best to go from there. But you really are gonna have to be seeing this person multiple times in order for them to then come back and say, okay, your labs are this, your MRI looks like this, I think it's, and then you might even have to push them and beg them, what do you think it is? Because a lot of times, you would have to ask. They might say, oh yeah, it's definitely some memory changes, or the person, maybe they do have dementia, but what type of dementia? No one likes to say, doctors don't like to say the word Alzheimer's, they don't like to say dementia, so I think it really is, and that brings me to, I mentioned it somewhere, the wonderful list the Alzheimer's Association has, questions to bring with to ask your doctor. You're going to have to push and say, what is it? Is it Alzheimer's? Is it vascular? Or do you not know enough yet and I need to come back in 6 months before you let me know what you think it is? The role for a neuropsychologist. So neuropsychologists do basically really in-depth testing, anywhere from 2 hours to kind of 6 to 8 hours of testing to really look at every realm of cognition, look at your processing speeds, and kind of lay out exactly where the cognitive trouble is. I think it can make a lot of sense to do this, especially if it's really early in the course and the person themselves is extremely worried about what's happening to them. But oftentimes what we see is people are referred to a neuropsychologist even kind of later in their course, and then the neuropsychologists, they're kind of leaning to the neuropsychologist to give them a diagnosis, but that's really not what the neuropsychologist is for. That's not what they're trained to do. So I think people are often inappropriately referred to neuropsychology, to be honest with you. I think there's a time and a place for it, but it's not everybody needs to go sit through 4 hours of cognitive testing to find out that they have Alzheimer's or whatever. So I think the psychiatry piece is interesting. We'll talk more about this, but oftentimes there can be a depression component that can be related to a yet undiagnosed form of dementia, or it can be separate. So it's really important to think about any component of depression or anxiety, or if the person has pre-existing psychological or psychiatric illnesses like bipolar disorder, schizophrenia. I think it makes a lot of sense to see a geriatric psychiatrist. Otherwise, like a general psychiatrist isn't going to really be super helpful, I don't think. And then the geriatrician, I saved the best for last. The geriatrician, I think, is a good resource because the geriatrician is really looking at the big picture more so. Well, that's okay. If your primary care provider is doing that, then you don't need a geriatrician. But versus a neurologist or a psychiatrist, the geriatrician is looking at what's going on day to day. They're looking at your medicines. They're looking a little bit more in depth about what other factors might be at play. So I think that's always a good thing. So evaluation on lab and imaging. So there's kind of no debate at all. Everybody should have their thyroid checked. Everybody should be screened for B12 deficiency. But there is still debate about how much of that is actually reversible. So if somebody comes to you with cognitive changes and they have a severe hypothyroidism, it's unclear. You can probably treat it and they can get a little bit better, but it might not reverse completely. There still might be an underlying pathology there that is going to continue to progress. So most professional societies recommend at least a CT scan to look for any type of chronic bleeding, to look for any signs of strokes, to look more rarely like brain tumors. and things like that. But again, if there's a primary care provider that's knows the person really well, it's not set in stone that everyone needs neuroimaging. So if you go to, depending on kind of where your workup is going, a lot of people end up getting MRIs. They have a really nice type of MRI now that measures the different areas of the brain, so they can kind of say like, oh wow, the memory center is really, really small, so that is kind of predictive more of Alzheimer's, or so that's a good thing. And then PET scans, you're really not probably going to get a PET scan unless you're going to like really specialized neurologists or even like Mayo Clinic type things, or you're really insistent upon it. So PET scans can be useful because they can actually show amyloid plaques in the brain, but it's not perfect again, because just because you have amyloid doesn't mean you have Alzheimer's, so it's not perfect. And then oftentimes, I think the better use of PET scans that's more often used is to differentiate between frontotemporal dementia and Alzheimer's. So they are used, not super commonly, and not everyone needs to have one. So normal pressure hydrocephalus is probably one of the big things we want to make sure everyone kind of knows about, because it's one of the few probably true reversible causes of confusion, and kind of a slowness and a change, and usually it's because of too much fluid building up in the brain, and there's a classic triad of symptoms, which is like a confusion, a change in your gait where it's wide base and the feet are kind of not lifting off the floor, and urinary incontinence. Can this happen to people in their 90s? Yes, probably. But at that point, if somebody has advanced dementia and they're in their 90s, it's probably, not super relevant. But if somebody's otherwise, in their 70s and pretty healthy, and this kind of comes on over weeks to months, that's definitely something to think about because it's treatable. That's a reason to get an MRI, and then furthermore, a reason to be seeing a neurologist, because then they need lumbar puncture and other things to treat it. So we'll talk about other red flags later that need a more extensive evaluation. I didn't mention, most people, syphilis and HIV, they're probably not tested for as much as they should be, but it depends on kind of the person's, where they're from and their risk factors, whether that's tested for. So besides that, what other testing is going to be done if you go, or what other questions are going to be asked? Your first step, probably not the neuropsychologist. You're going to have like a one-page, 10-minute memory test, either a MOCA or MMSE or SLUMS or something, where it's just a quick test that breaks down, several realms of cognition, and brief overview of like, have you guys seen one of these? Like, can you draw a clock? Name that animal. So that's the brief thing. An assessment of daily activities, so the practitioner can better understand what the person's level of function is. Like, can they use a remote? Can they go for a walk on their own? Do you worry about them getting lost? Can they use the bathroom? And then really importantly, I think, an assessment for depression and anxiety, because that is a true mitigating factor. Might not be truly reversible, but it's truly mitigating. As in, if it's treated, the person can have a better quality of life for longer. An assessment for sleep apnea. Usually it's not sleep apnea alone that is leading to like profound changes in memory, but it definitely can contribute. And then assessment for hearing loss. This is funny because I think we've seen it. People misdiagnose with dementia because they can't hear. So red flags, these are people that absolutely should see like the top specialists, probably, people that are younger, rapid onset, because there's a lot of other, there's a lot of things that cause, changes in cognition that aren't Alzheimer's or aren't strokes, aren't Lewy bodies, other autoimmune diseases, other infections. And then in the younger people, I think that's really more commonly too when you're gonna get an assessment, if you ask especially of like the biomarkers, so like a lumbar puncture to look at, is there amyloid there, and the blood test that's coming out for that too, that will probably be really, really big one day. And was I gonna say anything else about that? Oh yeah, if somebody has a neurological deficit, like all of a sudden their hand grip is weak or something, they should have brain imaging, so they maybe have had a stroke. So that would be a red flag, I think, stroke-like symptoms. Okay. Oh, and I also want to say too, this is probably just true in life in general, but the more insistent the person is, like the more workup they would get. So I think we've all seen that. So like if you want all of the workup done, you can get it. You can get a PET scan for the amyloid, and you can probably find your way into getting biomarkers checked and stuff, but most people don't really need it. Okay, so what other factors? So this is probably the most important. This is really important. So a lot of inappropriate medication prescribing happening out there. Muscle relaxers, anti-anxiety pills, sleep aids, things that are known to cause confusion, falls in the elderly. So inappropriate prescribing is a massive problem. Or even I always ask, I had this funny lady who she had to take Benadryl. She wanted to take Benadryl every night before she went to bed. And her daughter was saying, she's waking up woozy, she's more confused. But then every time I would go back to her apartment, their Benadryl would be back. So she was kept finding her way to get it, but that was causing problems for her. So what sleep aids are people on? This is a really big deal. The anxiety and depression we mentioned, stress. So stress, stressful on anyone's brain, not to mention somebody's brain who is going through a neurodegenerative process, accelerated from somebody who otherwise has normal age-related problems. Alcohol, we see that, oh gosh, and that's really obviously a horrible struggle. When people have memory loss mixed in with excessive alcohol consumption, it's an extremely difficult challenge, I think, for families, for society. We struggle with it, trying to help people through it, certainly. And then also something to think about too on the alcohol. I would say if we have people coming in where they live in a controlled environment, like they have a spouse, they're not living alone, but they're having behaviors in one way or another, we always really suggest limiting or completely taking away the alcohol because they really do exacerbate behaviors. And then delirium, okay, this is an important thing. So once people are getting kind of into the system, so like they're in the hospital, then maybe they end up in the nursing home or what have you, and they have an acute change in their cognition, which is not related to dementia, it's related to delirium, which also is called colloquially acute brain failure, which is really what it is. It's total disturbance of all the neurochemicals, so that the normal thought processes cannot happen. This is interesting because if your brain is sensitive because of whatever process is, you're more likely to get delirium. But also delirium then leads to more commonly getting dementia. So they kind of are interrelated, but anyone can get delirium. A friend of mine, pediatric oncologist, was looking at kids in the inpatient unit getting chemo, and there was like 5 or 10% of kids that get delirium. So it doesn't just happen, it happens to everybody, all ages, and it's a serious problem.
Can you say a little bit more about what that looks like for somebody?
Oh.
What would they
Okay,
notice?
so, yeah, sure. So what delirium looks like, mainly it's an acute change in their cognitive state. So maybe they're way more drowsy than usual, so like a change in their level of awakeness. So a lot of people in the hospital, You know, they think older adults in the hospital, people think, oh, they're just resting. They're sleeping 18, 20 hours a day. They're not really resting. They really have delirium. So I would say the main thing is the acuteness of it, that it's a change from their baseline, and that a major lack of attention or focus, and then either like hyper aroused and like very vigilant, very active, you know, pulling at things, touching at things, or the opposite, like kind of lethargy, stupor. So that's a really big deal, and it goes you know, overlooked really in hospitals, and you know, some people think they're fine, some people don't. And I was reading something interesting that people that come saying that they notice their own memory like loss are more likely to have a component of depression, which I thought was interesting. So what should you do if your loved one thinks they're fine, or if their loved one is you know, agitated, or they're mad at you, like they don't want to go be evaluated? What I would say is, or you feel like you can't talk in front of them, which we see that. So you guys probably have tips for this, but my tips that I thought of were you can write a letter with exactly the timeline, the symptoms that you've seen, and you can just hand it to the doctor when you get in. You can call ahead. That might not be as sure of a way. Call ahead and speak to the medical assistant and say, this is what I need to get across to the doctor. But ultimately, it's very hard. When I worked at the university, people would find a way to talk to me alone in the hallway. But it's hard, it's hard to always get that done. So that's always good too if you can manage it, certainly. And actually with telemedicine now, I wonder if this is getting any better. But I still think you would have to ask, I think, to have a visit where you could speak freely, where your loved one's not going to say. Ultimately, in the interest of your loved one, or whoever it is, to get a diagnosis, you should give as much information as you can to the practitioner so that they can make their most educated guess as to what they think is going on. And then I guess if the person's really mad for that moment, I had a guy tell me, he was a retired radiologist. And this poor guy, he was alone, you know, and clearly struggling. And first time I met him, and I kind of wonder if this was the right thing to do. I told him, I don't think you should be driving any longer. He goes, do you know who I am? And really, but then the next time I saw him, he liked me again. He'd forgotten all about that, and he drove to see me. So, in this case, we were saying how this disease really affects the whole family. So you're trying to support the patient and the family. So if the family member's saying to you, oh my God, they've been crashing their car, they keep driving, we can't, but they don't want to be the bad guy necessarily. We come across this a lot too in our line of work. The people disclosing about their suicidal thoughts, and I was just listening to a podcast about how the risk of suicide goes up in people newly diagnosed with dementia. So, and then people don't want to tell because they don't want, the crisis hotline or whatever to be arrested, petitioned, whatever happens. So I think there's a lot of to me that's like a societal, we're screwed up somehow if that's what we struggle with. So we also, oftentimes we meet our patients and they tell us we thought the neurologist was going to help us more with how we're supposed to get by day to day, and none of that happens. So they have no education on how to communicate with the person, how to coax the person into the car or into the shower or what have you. So we really try to kind of support our patients in that space, I guess to say, how to maximize success each day. So, and lowering, in turn, lowering the stress level of the loved ones. We talk a lot about routines. We talk a lot about appropriate communication techniques. where we tell people, don't correct them, don't argue, just get out of, they're not living in reality anymore, it's not their fault. You need to just join into their reality, because everything the outsiders do that increases the stress level of the person is ultimately bad for everyone. So we think about that a lot. And then behavioral and psychological symptoms. I mean, this is a massive issue that's really not, again, societal, the medical, just propensity just to put people on medications, by and large, not managed well. A lot of like the environmental and the ecological and psychosocial changes that could be done to help with whatever behavior the person is experiencing are not done. It's just a lot of unnecessary prescriptions happening. So that's, I think, an area where there's just a lot of growth that needs to be done in caring for older adults with neurodegenerative diseases. And I think the more education, and you can see it too, like some people are naturally attuned and some people are not so naturally attuned, but the caregiver or care partner really has to be willing to learn new techniques in order to ultimately, hopefully, spare kind of sedating medications that are just, really we try to use as a last resort. So planning for the future. So why it's important to find out early what's going on, then you can kind of start to think, and I'm sure a lot of people sit down with their financial planner and they say, okay, if I have $4,000 a month, can I do in-home private duty for this many hours, or do I need to move my person to a memory care facility, or how is that exactly going to look? Not everybody ultimately needs to move their person. Not everybody needs 24/7 support of a caregiver. Every case is different, every family is different. But also sometimes it seems like traditional too, like some people think like that's just what you do. And the funny thing, we were looking at books, children's books about Alzheimer's, and about half the books, they moved the loved one to a facility, and about half the books, the loved one stayed home. So I thought that was really interesting. And kind of a interesting societal thing too. So the formal and informal caregivers, that's kind of something to think about. If you have other informal caregivers, meaning like family members or friends that will be willing to help out, community supports, a number of nonprofit agencies offer volunteer services. We just came across a group that equips the homes for people that live in rural areas, grab bars and things like that. But then just even knowing about your housing options, I think, is great. Then you kind of have an idea of the landscape and what you could be in store for, depending on what happens. So I think this is the most important thing: the dignity for the loved one, which could be, which ultimately could be anyone. So we suggest asking people really specific questions. Would you ever want tube feeding? What level, what quality of life is going to be acceptable to you? So if you're not communicating at all with your surroundings, and I've been forced to put you in a nursing home, and you get pneumonia or you have a stroke, should I put you on hospice? Would you like to just die then? Or should, naturally, obviously, from whatever happens, or should you be put in the hospital? Should the infections be treated? We think trying to be as specific as possible is the best way, because that's the best chance the person's going to get their wishes met. Because even if people write things down, like they want to have a do not resuscitate, and then the medical power of attorney kind of still feels it's their decision to make, even though we're saying no. They wrote it down. They made the decision already. So it's much, much better if the person, if nothing else, can have a say what they want the end of their life to look like. Because a lot of, really sad things happen to people, especially with people with really bad paranoia and really bad delusions that are, won't take any medications because, who's trying to kill them, and then people like that are aggressive really are treated the same way as like a 20-year-old that's high. So it's really devastating and, so yeah, whatever we can do to prevent that is good. I think that's all I have.
Really good. I mean, great opportunity for questions and answers. Any questions or comments for Dr. Self?
Yeah, you mentioned MMA, an acronym that I associate with mixed martial arts.
Sorry. It stands for methylmalonic acid. So it's actually should be the treatment of the test of choice to assess for a vitamin B12 deficiency rather than a B12 level. But that knowledge apparently, interestingly, it takes 15 years for like medical knowledge to kind of end up, in the minds of all of the ancillary or whatever community primary care providers, which is interesting. So that might, but it's going to become commonplace that people order the methylmalonic acid level instead of the B12 level because it's a more definitive test. So thank you for asking.
Thank you.